role is administrator, but she is more than administrator. She has been engine that has been driving Iowa at very high speed. I'm sure you have been noticing with all the activities that we have been doing. So I would like to recognize Reta. Um, about briefly about Iowa. Iowa is um, association of the members. So we have now 42 associations. Sorry, my nose has some issues. So, and we have recently, for example, Nigerian Association of Occupational Hygienists, and they have joined Iowa. Iowa has started offering this webinar since last year and a half. We have offered about 16 webinars. These webinars are free for all those who are member of Iowa. And others are paying. So if you are not member of Iowa Association, if you are not member of Iowa Association, and if you have not paid for the webinar, you should log off now, right? That's a benefit that we would like to give to our members. I would like to also recognize Natalie, who is in the webinar today. She is a treasurer at Iowa and plays a very pivotal role in managing finances. And I'm looking at the list here. So with that, I would like to start the webinar. Rita has indicated that we are recording this webinar. Currently, we are creating a web page for members only, and this recording and the presentation will appear there. We plan to translate this into Spanish language also. I know Ana is joining from Chile, and we will include, share with you the Spanish version. The webinar today is on emerging issues in respiratory protection, and it's going to be for an hour and a half. I would like to thank, on behalf of Iowa, Stephanie Lynch, who has volunteered to spend her time collecting the information and presenting this to us today. We may do the same webinar sometime in future during evening hours of US so that people from Australia and other part of the world can attend. Stephanie is a senior technology and research manager for OHD LLP in Birmingham, Alabama. She manages a research project, serves in several committees. She has about 20 years of experience in IH safety across all types of industries. Um, and she is more pivotal, more important part is she's involved in the research in advancing the partnership with regulatory agency and other organization. She is a professor, adjunct professor at the University of North Alabama, and she is also at OSHA Training Institute. Um, she has a various background in different types of area, and she is also vice president of the International Society of Respiratory Protection. So this is what voluntary work that some of us have been doing in this profession. So with that background, I would request Stephanie to start the webinar. There will be, you will have an option of leaving the question in a chat. And so my suggestion right now is that insert your name in chat and insert the country and association that you're representing also in the chat. Do this during the webinar so that we know from which country and which associations you are attending the webinar. So that's all from my end. Thank you again. We will keep offering similar webinars, and we would like you to participate in the future webinar as a faculty, if you would like to, or as a member to attend. With that, Stephanie, and the floor is yours.
Thank you, Maharshi. So, hi, everyone. I'm so pleased to be here. I am Stephanie Lynch. I've been working with respiratory protection, most specifically respirator fit testing and associated research for more than 20 years, which actually is a bit depressing to realize. I did take a few years to sort of broaden my horizons into the wider world of industrial hygiene, but I am more focused now on just a few IH sort of hot topics. So respiratory protection and fit testing, air and noise monitoring and exposure, heat stress, ergonomics, and vibration exposure. Maharshi mentioned that I'm the vice president of the ISRP. So the ISRP is the International Society for Respiratory Protection. I'm also the chair of their education committee, and we're always looking for volunteers to help. The ISRP is all about really educating people about respiratory protection. We've had some focused projects lately on general populations that have really bad air pollution exposure, or volcanic ash exposure was one from just a couple years ago. Well, I guess longer than that now, but stuff like that. And we really are always looking for some help. Our education committee is getting rolling again with some workshops for a project called Face Up, and we'll talk about that later because I think that is one of the emerging issues in respiratory protection. So I want to take this time to focus on respiratory protection, sort of where we are and some places that we may be going. So I hope you find it valuable. And I really hope that you can at least occasionally jump into the chat and make it a bit more interactive. It makes me go just a bit kooky when I'm just sitting here talking to my computer for a long time. And I actually, unfortunately, might be a little more prone to kookiness than usual because I had an ISO committee meeting from 5 to 7 a.m. this morning. And so it's 7:38 my time now. I'm in Alabama in the States. So the main Okay, I'm going to kind of start with respiratory protection basics. And I know that a lot of us as occupational hygienists may be familiar, but I feel like ignoring the foundational information may be one thing that's contributed to a lot of misinformation. I also just want to go ahead and say that sort of my main point in all of this um, is that there is, at least in my opinion, and I should state that first and foremost too. While I am the Senior Technology and Research Manager at OHG, and I am the Vice President of the ISRP, I'm speaking to you today as Stephanie Lynch, as myself. So all of these are my thoughts and my feelings for sort of where we are and what it means and what maybe some things we need in the future. But my main point is that there's an overwhelming need for a global standard to address not only occupational use of respiratory protection, but also its use by the general public and even more specifically children. And I don't say that lightly. I understand the amount of effort that would take. Seriously, I've seen comparable undertakings, and I've seen them done with pretty noticeable shortcomings. But it's worth telling all of you so that maybe different groups can combine their forces and make meaningful progress here. I would really like to see a shift in the focus of regulation from being, less to the T and more about accessibility. If people feel like they can easily find out how to use a respirator appropriately and when it's appropriate to use it, I think that'll increase adoption of use. And I think as we move forward in the future, there are going to be more occasions where you'll need to use respiratory protection. I know several organizations that I'm involved with, ISO, CSA Group, ISRP, are trying to do their part, and it's really encouraging, especially when you consider that most of those individuals are volunteers. But I still would like to see that shift in focus to really where we're just getting more people comfortable with using respiratory protection and more people using it correctly and getting a good fit. I think well, anyway, so we'll get started on that. Believe it or not, the very first challenge with regards to respiratory protection is actually defining it. And of course, the pandemic really complicated that a little bit, I think. So you may know what a respirator is, but I would encourage you to ensure that anyone working with respiratory protection has that same level of clarity. Because of the pandemic, there can be a lot of confusion, what a respirator really is. So a respirator is going to form a tight seal against the skin. It's going to cover at least the nose and the mouth, and it's going to limit exposure to certain airborne contaminants. There are air purifying respirators, which are going to include those filtering face piece respirators that have become so prevalent, elastomeric half and full face respirators, and powered air purifying respirators. Just as a note, there is a loose fitting version of a powered air purifying respirator. So these are all listed across that top row. And then there are air supplying respirators. So those are the first two, the supplied air respirators and the self-contained breathing apparatus. Those are those first two on the bottom row. There are also combination respirators that can be used as both air purifying and air supplying. So I put the link to this. I imagine you likely can't see it great, but I think everyone's going to get, at the very least, a PDF of the presentation. And I've placed the link anywhere that I've used someone else's resource. So it can be helpful in just explaining those differences. And while there has been innovation, it's kind of one very soft silver glimmer from the pandemic is that there's been a lot of innovation in respiratory protection, but everything that I've seen thus far doesn't really alter these definitions, at least yet. So, maybe we'll see. Another incredibly important aspect of respirator selection, and honestly, this comes first as an aspect of, exposure assessment, right? You wouldn't even be selecting a respirator if you weren't aware of an inhalation hazard in the workplace. So this needs to be well defined, like whatever exposure you are facing. But once you've selected that appropriate respirator, you want to make sure that it's equipped with the correct filter or cartridge. I bring this up because I actually saw this more through the pandemic with regards to fit testing. I've had customers, for instance, use irritant smoke with what we here in the US would call an N95 respirator. Can anyone drop in the chat what the problem is there? I mean, the problem is that you need a higher level of filtration to actually filter out that irritant smoke, right? Same thing would happen if, I don't know how globally implemented the use of banana oil is, but if you're using banana oil, you need the specific organic vapor cartridges to filter out that banana oil. Luckily, these cartridges, this is the US listing, but I think that in those places that have regulation, they're going to have something at least similar, are going to be color coded. Unfortunately, those FFRs or FFPs, so the filtering face piece respirators, don't follow this guidance. So I'm guessing they're considered an exception because the mask is made up entirely of the filtering media. So it's simply not a cartridge or a canister. I really don't know. And I'm honestly surprised that I haven't wondered more about this. I did reach out to a colleague here in the States at NIOSH, so the National Institute of Occupational Safety and Health. They have a lab. I used to work there. It's called the National Personal Protective Technologies Laboratory. And I was told that they're not sure why it's allowed for manufacturers to differ from the typical color indications, but that they do enforce the coloring surrounding the P100s. They said violet magenta, and I think that's an interesting point because if you look in my chart that I have, it says purple. And I'm not saying there's a huge difference there between, purple, magenta, violet, but it is interesting that, NIOSH to OSHA, even that subtle change. So if a respirator is deemed too close to that color code, then it's not going to be approved. They did also say that because of all the approvals that are now in place for filtering face piece respirators, that it's too late to go back, essentially. So yeah, I do think it's essentially alignment across all respirators to include filtering face piece respirators and global application, and matching up would be beneficial. I don't think I made this glaringly clear, but so NIOSH is the certifying body here in the United States for respirators. I recognize that this can be quite different from other countries' certification process, and we'll sort of touch on that, at least the difference between here in the US and then what I've seen in Europe so far. But for the filtering face piece respirators, NIOSH classifies the filtering media based on two things, its resistance to oil and then its filtration efficiency. So N has no resistance to oil. That's what the N in N95 means. The R is somewhat resistant to oil, and then the P is oil proof. So it's really interesting to me that here in the US, so then particle filtering efficiency, that N95, that 95 is indicating a 95% filter efficiency. So it's designated either 95, 99, or 100. That's actually 99.97. So it's shocking to me that what is essentially, for the United States, the lowest level of respiratory protection, so a filtering face piece respirator with 95% efficiency for filtration and no resistance to oil, has been what's become synonymous with a filtering face piece respirator. As a matter of fact, I now read plenty of papers from industrial hygienists where they use that term N95 interchangeably with filtering face piece respirator. When shortages began in the pandemic, I was able to go buy P100 filtering face piece respirators with no problem. Now, eventually it became difficult, but I was able to buy those, donate them to local hospitals with no problem. And, and that kind of highlights an issue, right? There's a public health communication problem when employers, especially in healthcare, aren't aware that there were other levels they could have progressed to provide protection to their employees. So I just want to highlight that. Counterfeit respirators, especially the FFRs, started popping up all over the place. And although I've seen less of this very recently, I still see discussions within the regulatory and standard setting groups about the ear loop respirators. So ear loop respirators are very unlikely to make a tight seal to the face, and at least according to NIOSH, without a fastener to connect them behind the head. So a self-described respirator with ear loops is a good sign that it's a counterfeit respirator. I don't actually know the stance. I know we're working with CSA Group now for our stance on ear loop respirators. As of now, it's pretty aligned with NIOSH, and I haven't seen it come up on the ISO group yet, but the consensus is pretty good that they're not going to form that tight seal on the face, although they may still be better than some of the cloth masks that we've seen and some of the surgical masks that we've seen. Another good sign is if it doesn't have all the required markings, and I imagine this would go, sort of globally. These are the markings required for NIOSH, but I would hope that anyone who is certifying respirators, so like the CE mark, those notified bodies in Europe, they're going to have outlined what the respirator should have on it. And you would be able to identify something that's either misspelled or incorrect or just missing, and that could help. So just another area where global standards and marking
Sorry, Stephanie. Someone has put you on mute. So if you can just unmute yourself again.
Yeah, please.
Well, that's very rude. Where did I stop?
I think if you can start at the beginning of this slide again, it will be great. Okay.
So here are a few of the recent user notices here in the US for counterfeit respirators. That's also to include a counterfeit P100. We just talked about that NIOSH won't approve ones that are too similar a color to what's considered the P100 color here in the US. So KN95 labeling has also clearly confused a lot of people. And I think that because some KN95s did manage to pass NIOSH certification and still others passed FDA certification. So that's a whole other thing here in the US. The Food and Drug Administration is actually who certifies our surgical masks, for instance. So as well as the fact that the CDC authorized KN95s for emergency use, these things sort of muddied the water, right? It's very hard to clarify and correct little snippets of knowledge that were passed along during the pandemic. So when everyone's like, okay, KN95s are good. And so, sorry, KN95 labeling indicates a respirator met Chinese standards, but I'm sure you can imagine that counterfeit KN95s would have already existed the same way that counterfeit NIOSH approval for respirators existed in our market here. And so the pandemic just exacerbated that. I also added an older example of the misspelled NIOSH here, because that was something that I actually saw out and about. And then another mask representing that it can fit children. And while I'm not even sure if it states it outright, you can clearly tell that it's indicating it's a small size, and then the pictures, look like children, and that's still misrepresenting. So this is my first example of the differences we see across countries in how respiratory protection is discussed and defined. So we just went over those US FFR designations. Well, in Europe, it's already called even just a different name, right? So filtering face piece respirators in the US, we take the FFR. In Europe, they take the filtering face piece, so FFP. And that's the European equivalent. I have to use the quotes because they're not describing the same things. They're not split up at all in the same way. FFP1 masks are going to protect against non-toxic water and oil-based particles. The total leakage of an FFP1 mask is a maximum of 22%, and at least 80% of contaminants are filtered out of the inhaled air. So common applications for that are going to be just environments with low levels of non-toxic dust. FFP2 masks protect against harmful water and oil-based particles. So the total leakage of an FFP2 mask is a maximum of 8%. At least 94% of contaminants are filtered out of the inhaled air. So this is the more equivalent to that N95, although the no oil is not applicable here, but still. So then FFP3 masks protect against harmful and carcinogenic water and oil-based particles, as well as radioactive particles, airborne biological agents of particular risk groups, and enzymes.
साईं वालेकुम सलाम सर छालन ता बुधायो तबीयत शरीफ ठीक है
Sorry, can whoever's got their microphone on just put yourself on mute?
Okay. I'm good now. Okay, not muting. Okay. Where was I? FFP, I think I was talking about FFP3 masks, right? Okay, so the FFP3, they're protecting against harmful and carcinogenic things, can also protect against some airborne biological agents. They're going to be a maximum of 2% total leakage, and then they're going to filter out at least 99% of contaminants. So there's clearly a lot of variability across how we define these masks, these filtering face piece mask characteristics. So one critical aspect of all of this is then, as an end user, what would you expect your level of protection to be when you wear one of these respirators, really any respirator? So that gets us into assigned protection factor. And I apologize, this is a very wordy slide, but it's intentional, because these are some of the definitions that I found just with a very quick search for assigned protection factor. And I think this speaks to a lack of clarity on what exactly an assigned protection factor is. So what level of protection can you get and what it really means. This makes it very difficult for an end user to apply an assigned protection factor in the way that they might want to. ISO actually describes it as a protection level and defines it as a degree of respiratory protection that's allocated to a respirator for the purposes of selection and use, that is expected to be provided when wearers are using that mask within the context of an effective program as described by ISO. And so that's clearly quite similar to the OSHA definition, but the respective values assigned by OSHA and ISO don't always line up. A note on 3M's definition, it goes on to say that APF is based on the 5th percentile of the workplace protection factor of the workplace protection factor data maximum allowed occupational exposure limit. And then they define occupational exposure limit as the limit of the time-weighted average concentration of hazardous substances in the air within the breathing zone of a worker with respect to some amount of time. And I'm sure I didn't get that exactly right, but is it clear from just me saying that the language in and of itself is a barrier to the application of respiratory protection for any just layperson? So the applicability needs to be based on the end user. Even my language, as I'm talking to you guys who are all, occupational hygiene professionals, we probably don't have the best baseline for what is or isn't a barrier, but this language is a barrier, and there definitely being so much variability is another barrier. People are just going to go, well, I don't understand it, so why would I even apply it? Or they're going to pick what they do think works for them and do it that way. So a little bit about the determination of these protection factors or protection levels. Again, different ways of talking about it. I didn't even mention that I'm using the term respiratory protection or respirator, and I'm probably using them interchangeably. But within the context of a standard or a paper, you would have to pick a term. So is it respiratory protection? Is it respiratory protective device? Is it respiratory protection equipment? So you have to upfront try to kind of divine it and stick with one term. And the fact that we have these different terms is just another sort of hindrance. So APFs are determined by either the government or a standards setting organization. So I listed just a couple here because I could have kept going really forever. But NIOSH, ANSI, these are both things within the US. Those are standard setting groups. The CSA group that I participate in, ISO that I participate in, both of those are international. CSA did start in Canada, but it is trying to be a more global standard. And then the government, so OSHA here in the US, HSE in the UK. But anyway, there's still so much variability from these countries, even if multiple countries select ISO as their reference. There can be countries who adopt without enforcement. There can be countries who I've seen where Germany sort of conflated the terms for a respirator fit test and a respirator wearer seal check. And so it kind of has a little bit of confusion there for what people need to do and what is required, where I think they really just kind of made it recommended. Or they introduce things like ISO with exceptions. So these are the respective protection factors assigned to the FFP 1, 2, and 3, respectively, from the HSE. This is clearly very different from the guidance in the US because in the US, all FFRs and half face piece respirators are assigned a protection factor of 10. And of course, other differences exist. While serving on the CSA working group, we've had to look at differences in assigned protection factors and then justify our selection of one. So we can kind of see this a bit on the next slide, but just with what this means. So FFP1 masks may be used with contaminant concentrations up to 4 times the workplace exposure limit. That's what that protection factor of 4 means. FFP2 masks may be used with the contaminant concentrations up to 10 times the workplace exposure limit. And that's the protection factor applied in the United States for all of the filtering face piece respirators, as well as a half mask elastomeric respirator. FFP3 masks may be used with contaminant concentrations up to 20 times the workplace exposure limit. So this is all the same way you would apply the assigned protection factor, but the protection factors are very different. So some of the considerations that we had to make on the CSA group revolved around what direction essentially to work. So there's a typical, very general idea of taking the assigned protection factor and multiplying it by 10 to get a reference passing fit factor. And we're going to talk about fit factor and how it's defined a little bit later. But so a respirator with an assigned protection factor of 10 would then require a fit factor of at least 100 to be deemed an adequate fit, meaning that it would be at least capable of providing protection to reduce exposure to some harmful substance to a tenth. However, with some of these respirators, that assigned protection factor is assigned based on the application of positive pressure. So, but then when you fit test the respirator, it's tested in negative pressure mode. So if a wearer would only use the respirator in that mode, so under negative pressure as an APR, and that's the mode in which it is fit tested, then what is the appropriate reference passing fit factor, right? Because it's not going to be associated with that assigned protection factor. And should we adjust what we're saying is the assigned protection factor if we're not going to then subsequently test it? Because these are based on sometimes very loose workplace studies, things like that. So I clearly kept the FFP 1, 2, and 3 out of this listing just to simplify. The UK has those 3 assigned protection factors, but they are not reflected in the reference passing fit factor. They actually set it all for 100, I believe. I'm pretty confident on that. This is a chart of all the various fit factors, and there really is a shocking amount of variability across the different standards. So as if that weren't even enough, another notable term that I haven't even touched on is maximum use concentrations. And so that's that maximum concentration of an airborne contaminant from which an employee is expected to be protected when wearing a respirator, determined by taking that assigned protection factor, which we've already seen has a ton of variability, and then the occupational exposure limit, which I'm going to discuss later, also has a lot of variability. So that maximum use concentration would usually be determined mathematically by multiplying the APF by that occupational exposure limit that you're referencing. This is just another area where I believe employers struggle with both comprehension and implementation. And I would think that this is in part due to all this different terminology, all these different numbers, and the differing exposure limits and the terms for those, which we'll do a little matching slide here. These are some of the different acronyms for the terms we use to describe an acceptable limit to an occupational inhalation hazard. There are several exposures for which literally all of these are different. And 2 quick notes here. PowerPoint's design ideas had offered something I swear I would have used it, but I gave up. But the other is just that this isn't even, a fully comprehensive list, I bet. But here's how they all end up matching up. So occupational exposure limit, one example of who uses that terminology is actually IOHA. Workplace exposure limit, you'll see that within the context of HSE in the UK. Permissible exposure limit is here in the United States with OSHA. The recommended exposure limit is from NIOSH, also here in the US, and then the threshold limit value is from ACGIH, another organization here in the US. So here's how they line up. I really do doubt these are all the terms. I don't think I'm doing that.
Sorry, Stephanie, I muted everyone. If you can just unmute yourself again, thanks.
Okay, we good?
Yes, it sounds like it.
Okay. Hearing yourself talking back at you is maybe the worst thing that happens in a presentation.
Sorry.
No, that's not your fault. The joys of virtual presenting. Okay, so the reason that the US has all these different organizations making limit values is because our government is very slow to actually make a change. So the permissible exposure limit here in the States is likely the least conservative and essentially bare minimum you could legally keep with regards to health protection. So ACGIH TLVs are updated I mean, the book comes out every year. I imagine they look at them at least on a regular interval. And then NIOSH recommended exposure limits. As NIOSH is able to do studies, they will update those recommended exposure limits. So there are many cases where those here in the US can be different. There's also this whole idea, we could do a whole talk, and I'm sure people have, on all of the new chemicals that are made probably every day, and the occupational exposure banding that you would have to apply, essentially based on, similar existing chemicals, which is, of course, quite complicated. But even with the simple differences just between occupational exposure limits and why they exist, contributes again to this confusion and inaccessibility of occupational hygiene concepts, particularly with regards to respiratory protection. So fun little game. If you haven't dropped in the chat, tell me which one you use and where you are. Which one of these acronyms is your recommended acronym for a workplace exposure limit? So one thing, a recommended practice in most of these standards and regulations is with each donning of the respirator, for the user to perform a wearer seal check. So this guide has far too many words. The guidance is relatively good. I personally would recommend positioning the bottom strap first as far as the donning procedure, in an effort to help reduce that crisscrossing of straps. And a simplified version of this could be quite helpful. And this is something that the ISRP Education Committee plans to do. We plan to create really accessible, high visual, low words, so it's easily translated, to have some really good guidance for end users. And generally speaking, we do seem to be doing that more for the general public, but I think it applies just as much in the occupational setting, because I think a lot of people are using respirators and aren't as well trained as maybe they should be. And that's because whoever is providing it to them isn't as informed as they need to be, right? So just wanted to touch on the wearer seal check. Want to jump now into fit factors and then hopefully into fit testing. So the use of a fit factor is actually something, so this is just another sort of issue I have with what regulations and standards have decided to do with regards to respiratory protection. The use of a fit factor has actually been quite limiting to the introduction of new quantitative fit testing technology. Like, this is in part due to the established relationship that we just discussed between assigned protection factors and fit factors, as well as, your maximum use concentration, all these things being all connected together, as well as defining the fit factor initially based on the technology that was first used, so aerosol technology. This essentially means that if you want to introduce a new fit testing technology, you're going to have to show that you are equally protective, which is good, of course, but you would also have to have a means of calculating a meaningful and essentially comparable fit factor. So these are supposed to be connected to total inward leakage, but these measurements are typically made with aerosols also. I've seen some research with gas. I can't remember which one now. SF6 or something. Doesn't really matter. But even the ability of the method to measure that in a different way from aerosol penetration and expect similar numbers seems unlikely just intuitively. And I've experienced this with controlled negative pressure fit testing adoption. We'll discuss that. But so people have an expectation of what their fit factor will be if they do fit testing. And then if they don't see a number that's similar to that with a new method, it can create a lot of confusion. And so there's something about this fit factor that I feel like really does inhibit innovation a little bit. And we'll roll into those different methods just a little bit. We're just going to just touch on them. So the full protection that is afforded by respirators, to include those FFRs, is really only ensured if that wearer undergoes fit testing and then is trained to use and care for their respirator appropriately. You'd be shocked, well, maybe you wouldn't after the pandemic, but how many people just put their respirator on wrong? So a fit test is when we challenge the seal of the respirator to a particular wearer's face. The wearer will have already selected it as comfortable and should already be trained on its purpose, use, and how to maintain it. The challenge of that seal is going to be performed through a series of exercises, and those are going to be part of an approved protocol that's going to be approved by your regulation or your standard that you're following. It's going to be specific to whatever fit test technology you're using, and it's going to be outlined very carefully. Another issue that I see with respirator fit testing is this idea of just fit passing, where no one actually cares if they're really challenging the fit of the respirator. They just want to pass people. And that can't be the intent, right? We really do want to identify poorly fitting respirators to protect that person. These are all of the different methods that are available. Different regulations include some and preclude others, but this is all for qualitative methods. So qualitative is going to be relatively inexpensive, low maintenance. It is a bit imprecise. It is subjective. It is a little bit subject to cheating. When I did fit testing at a hospital for years, I was testing maybe 2,500 employees, and I think I only failed maybe 3 a year. And looking back, I realized it's because those were healthcare workers, and all they wanted to do was get back to work. And I was not at that point a well-informed fit test administrator, and I just thought, well, they said they can't taste it. So that's how qualitative works. Sorry, I kind of got ahead of myself there. But you put a hood on the respirator wearer's head, and you spray something in there that they can sense in some way. And if that substance is sensed, then the respirator is not fitting them well enough. It's deemed inadequate. Quantitative fit testing can be used for any type of tight fitting respirator, whereas that qualitative method is typically limited to those respirators only requiring a 100 fit factor. But quantitative can be used for any tight fitting respirator, but one of the methods, controlled negative pressure, is not currently able to fit test the filter respirators. So simply using an actual machine to measure the leakage in some way. Quantitative fit testing is going to be more expensive. It's going to require maintenance, typically at least an annual calibration. But the benefits are that these machines are going to be objective. They're going to provide documentation, which if you have a huge program, you're going to want. But the available protocols are also a lot faster than the qualitative method. So to create and maintain a negative pressure for CMP, this is one of the methods. There are 2 overarching methods of quantitative respirator fit testing. Controlled negative pressure is one of them. In the interest of full disclosure, my company OHD manufactures and sells this method, so I am quite biased, but I'm not going to try to not get into that here. To create and maintain a negative pressure, your respirator wearer is going to take a comfortable breath and hold it. The machine's going to initiate the mask being closed off, and then it's going to hold that pressure. If any air has to be removed to maintain that pressure, then the machine's going to work to remove it, and it's also going to measure what it's removing. And so that's how it's going to measure leak. It also has a way that it calculates its fit factor. We don't really need to get into that. And then clearly the single greatest limitation of our technology currently is that we cannot test the filtering facepiece respirators. So CNC or APC, again, just with the things we do within respiratory protection. So you're talking about qualitative and quantitative, as though those aren't already confusing terms for a layperson. And then CNC and CMP, so controlled negative pressure and condensation nuclei counting, or APC, ambient particle counting. Pretty sure that's what APC stands for, but just confusing terminology. So particles enter the CNC machine, they pass through a saturator tube where they're combined with alcohol vapor, pass into a condenser tube where that alcohol condenses on them, and it causes each to grow. It's actually magic that they don't end up growing too big, like scientific, magic. And then the particle concentration is determined by counting the light flashes. And how many particles counted inside the mask compared to those counted outside the mask is how you get the fit factor. Other direction though, outside, over, inside. But anyway, there's a whole nother process for the respirators with filtration below 99% that implements a differential mobility analyzer. So it's only measuring particles of a certain size. that size needs to be outside of the most penetrating particle size, and it uses that to measure leakage. So just quick, that is a quick and dirty. I do entire presentations on fit testing, so that was a very just quick overview of what's out there. So why do we fit test? Well, we fit test because hopefully we really want to protect the health of our employees. Poor fit has always been consistently found to be the largest contributor to low levels of protection. We want to make sure that our employees are trained on their respirator and how to use it and what it means with association to their risk. We also want to give our employees some peace of mind. There's something about people where if you're able to show them that their respirator is providing protection, I think it can really help empower them. And if you have the time to let them maybe go through a couple fit tests or even just a couple exercises and see the numbers just to adjust the mask and get some feel for maybe how it feels positioned on their face to get the best fit. I found that to be beneficial. I know none of us have time, but if you really do. But the direct connection or the most direct connection between why we fit test is whether or not it's required. So there's a direct connection between the requirement and the performance of fit tests. Here in the US, there are plenty of workers who are not covered by OSHA. And that's going to include a lot of the emerging issues we're going to kind of touch on. So volunteer emergency responders going, after a disaster, some firefighters, rescue and recovery workers. We have prisoners who do work in over half the states. To include, some of these prisoners are going and fighting wildfires, not covered by OSHA. Okay, I'm going to use the European example for the sort of regulation considerations. And this is just because I've been more recently exposed to it, and I assure you issues exist within any regulation. Hopefully I've made that clear talking about the US. So I'm not trying to pick on Europe. There's no overarching European standard requiring respirator fit testing, but I do feel like this standard specifying that PPE must fit the wearer correctly easily implies it would be good and it would be an easy way to demonstrate compliance. But some of the individual countries do regulate it in some ways that we'll see here. So I think it's very interesting that some of the countries require fit testing for substance-specific exposures, because you're acknowledging that there is a risk in exposing employees to either, asbestos or silica, and that fit testing would be beneficial. So how could it not be beneficial for anything else harmful, right? Also, it took us decades to see the full harm of asbestos and silica. So it just kind of sends this message, like, are we just waiting for more harm to be demonstrated? Also, I mentioned already, but within ISO, there's a high amount of variability in the different countries that have adopted it. So I think this is a huge issue when you look at, global companies. What standards should they apply, and where should it be the country they're in? Should it be the country with the most, conservative? How do you set those policies? And then it goes all the way down to this just end user, maybe in the general public, like a child. How does anyone know how to protect themselves and the general public looking at any of these standards? Well, I mean, they wouldn't, because the standards are outrageous. Okay, this is not an exhaustive list of all the approved protocols. And I honestly, considering I've made millions of PowerPoints at this point, I do not know how I got that to bring them in one at a time. I did not intend to. But this is quite representative of what you will see all over. And I really just bring this up to kind of point out that there are a lot of different regulations that are employing different fit test methods. And again, just kind of muddying the water. The modified CNC protocols that you see down here on the bottom right, those are sort of the newest emerging issue in respirator fit testing, at least. They're only in OSHA currently, but I know they're being considered for inclusion in the CSA as well as ISO, and it seems like these will spread globally. And I think this is a really big advancement for, again, accessibility of something having to do with respirator fit testing or respiratory protection in general, because they're both really quick tests And so now both technologies for quantitative methods have really quick fit tests, both less than 2.5 minutes to do a test. There are some differences even in different regulations. So the HSC, for instance, you have to pass every single every single exercise in the protocol, whereas in most of these others, maybe INRS is the same way, but in ISO and OSHA currently, at least, it's only the overall fit factor that's going to matter. So you could theoretically fail an exercise and still pass the overall test. Just highlighting another interesting difference, that these are just these things that I feel like we need to figure out a good way of ironing out without without hurting anyone's feelings, I guess. So another issue within respiratory protection, if you were to go get a fit test, who can do it? Is it just that anyone can do it? In some of our standards, it says a qualified person. Some people, it says a competent person. Others, it says knowledgeable person. Some people assume that if they have a program administrator, that person should be able to do the fit testing. Here in the US, we still don't have anything that would, I mean, you can go take a class on fit testing, but OSHA doesn't require that. It just says the person needs to be and the method they're using. So other countries have responded to this by creating respirator fit testing accreditation schemes. So in Australia and New Zealand, they both respectively have some. ResFit is the one that I am more familiar with because I've participated in its development, but it's supposed to help people have just a better baseline for going out and performing respirator fit tests. You can know that if you get someone who is ResFit accredited, then they know a certain amount of things. They were able to have knowledge, pass a test, and also show skills in performing a fit test. You have to video yourself doing a fit test. All of it's done electronically, which I do love, but you actually see the person perform a fit test. And the competence is based on the ISO standard. So ResFit is going to provide guidance and information for workplaces to essentially make an informed decision on fit testing, and that is appropriate and suitable for them. This is another scheme. So Fit to Fit is a scheme out of the UK. And I really wanted to just kind of use this slide for a couple different purposes. I didn't mention it, but with AIOH and with NZOHS, that those are both sort of organizations for occupational hygiene that have developed these representative programs. But in the UK, this scheme came out of a different thing. So BSIF is actually an industry-based group, and they have been able to make this Fit to Fit program. They want it to improve the respiratory health of those wearing respirators through being fit tested by someone who is accredited. And then the HSC has come behind them and promoted this, saying that essentially if you use someone who is Fit to Fit accredited, then you're doing enough to demonstrate good practice, according to the HSC. Okay, this is a very busy slide again, and it's a work in progress, but it's highlighting the spread of these fit tester accreditation schemes. And then I've started inputting regulatory bodies as I've become familiar with them. Clearly, this isn't going to hold up very much longer because I'm going to learn about more countries in Europe. But I thought it was important to show, the reach of these programs. And while Fit to Fit is clearly predominant, other countries really want to have their own thing for whatever reason. And while I want to be super supportive of that, I think it goes against what should be the more ultimate goal of health protection and ease of adoption, and sort of having, everything be more the same. That's not the right word. Again, been up since 5, have not had enough coffee. I've actually talked a lot about issues and opportunities for improvement within sort of global respiratory protection and respiratory protection program requirements and communication. But some of the emerging issues, so more like current event type concerns in respiratory protection for occupational use, are, of course, what we saw with the pandemic. I had customers calling to ask if they could hand out respirators to all of their employees so that they could safely continue working. And I had to explain that it's not that easy, right? You can't just hand out respirators. You'd have to implement an entire respiratory protection program, and then you would be acknowledging that COVID-19 was an occupational exposure. So then, what are the implications of that for employer liability? So the use of face masks is definitely going to continue to have more research and I'm sure more social commentary. And I really still don't feel great about the recommendation of people wearing face masks to work. I feel like a lot more is dependent on the proximity of people and the amount of time spent together. And I do feel anecdotally, at least, that people get a false sense of security from a face mask. So I would often see people in the workplaces that I cover sitting right next to each other for hours. And they're like, well, it's fine because I'm wearing a face mask. So I was able to buy in, I guess, for face masks as source control and kind of as a social cue. But I think it's pretty obvious at this point that the protective nature of masks has perhaps been overstated. And goodness, don't you wish we had never used the term masks to talk about respirators? Because I know I sure do. Another issue is wildfire smoke exposure in things like agriculture, so outdoor workers, and yes, even to the firefighters. So that sounds intuitive, like firefighters should fight fires, but the nature of that fight is different. The fires are different. They're burning hotter. They're burning longer. These folks are sometimes camped out at a site, getting continuous exposure. The current gear, to include the respiratory protection, is not designed with that in mind. So, we need work on the breathing resistance with long-term use and how that impacts work performance. And the interference with verbal and visual communications when you're wearing respiratory protection, right? So the changes in the exposure have changed the expectation of the equipment used. We're also seeing more types of natural disasters, and I'm primarily thinking of the ones that are causing flooding, but this could also be in relation to, a fire or even terrorist events. The exposures we saw after the recovery efforts of 9/11 here in the States have caused countless deaths. In Morocco, they just had that earthquake, and recovering those bodies and in those places, that's going to be its whole own thing. And how many of those people do you think are going to be wearing respirators? So talking about non-traditional occupational exposure, when I'm saying that, I'm speaking most specifically within that context of the need for the implementation of respiratory protection use due to increased exposure. But this is all about the increased risk for some of our essential workers during infectious disease epidemics that are based on having very close and very frequent contact with the public and other workers, right? So clearly, we would hope to implement higher levels of controls between now and the next pandemic, but we all know there will still be a need for respiratory protection. And the planning and education on how that can be accomplished could literally save lives and absolutely increase adoption rates. So I really do believe that most people want to do the right thing. It just needs to be as clear on how and as easy as possible to actually do it. So this would include comprehensive guidance on when exactly to implement this. I think some of us might agree that the use of respiratory protection could have been much more quickly and effectively introduced in this pandemic. That's due to a lot of things, but the how, like how do I implement the use of respirators in my workplace? Do I already have a program in place? Have I already at least thought about it? More and better supply chains, better management of stockpiles, greater use of elastomerics, really for just some of these occupational exposures where they didn't want to introduce respiratory protection, greater use of FFR still would have improved protection. But I think greater use of elastomerics could really help with the stockpiling and people being, assigned their own respirator, getting some of the benefits of taking some ownership of their own protection. Okay, I mentioned some of the issues facing firefighters, but I've also read there's a need for lighter weight respiratory protection. As far as agricultural workers, the only thing I've seen about this is that Cal OSHA has made an attempt to respond essentially to outdoor worker exposure. And so under that standard, if the air quality index for particulate matter 2.5, which is going to be those fine inhalable particles with diameters that are 2.5 micrometers and smaller, exceeds 150, then employers are going to have to allow for voluntary respiratory protection, which, just for the record, I wasn't aware that you could deny voluntary use of a respirator, but you then have to follow all applicable OSHA guidelines. And then if it exceeds 500, so if that air quality index exceeds 500, then, and you're also expecting your employees to continue their work, then employers are going to have to do everything to implement a respiratory protection program. And sorry, I recognize this is not limited to agriculture, but that is just a good place to start, and it seemed the most obvious. And also, it's already one of our sort of like least taken care of groups as far as occupational safety and health. So this is just in case anyone's not familiar with the air quality index, because again, I'm not sure if this is specifically a US thing, but our Environmental Protection Agency establishes this air quality index. It includes particulate matter 2.5, but that's not what it's limited to. It also looks at ground level ozone, carbon monoxide, sulfur dioxide, and nitrogen dioxide. So while wildfires are what I was specifically discussing and what come to mind for me, clearly all air pollution would be of concern. So the issues do need to be addressed from an occupational angle, but there's clearly more here, right? Within these issues, though there will be more employers needing to navigate respiratory protection programs, there's also a need for just the public, right? The public will have instances where they're going to be exposed to this too. Speaking of the public, so there are all those issues with occupational use of respiratory protection, and there are some emerging issues with occupational use too. A whole nother, emerging issue is respiratory protection for the public. And because there's not a regulatory framework, it makes it very difficult to understand the level of protection provided by any product against a known or unknown inhalation hazard. So filtering face respirators were the primary respirator used by the public, but that's if they're even using a respirator. It was much more often to see people wearing either their medical masks or a barrier facial covering. However, even with the filtering face piece respirators, current approval, at least here in the US, does not evaluate for facial fit, at least does not necessarily. And clearly the public is very unlikely to undergo a fit test. So also these masks can be very uncomfortable, and it feels better if it's leaky because you're going to get air more easily. So they have a relatively thin sealing surface, which means that filtering face piece respirator in some instances is placing a lot more stress within that tight seal on a smaller surface area. We saw that with a lot of the nurses. I think I have a slide on that. So it should be clear by now that the ability of a wearer to don the device correctly, and by the way, this is my friend Dawn, shout out to Dawn Elswick for being my model here. There's relatively little research quantifying the fit achieved by members of the public when respirators are used. There's probably more now, but I've struggled to find good references. So please let me know if you are aware of some. A lot of this is because the general acceptance of the public to wear masks and facial coverings. So I've seen a lot of stuff on the masks and facial coverings, but I imagine that has something to do with it. So anyway, in one study of untrained wearers, less than a quarter of those people were able to actually don their respirator appropriately when asked to do so. And then, so the common errors were that they wouldn't adjust that nose piece. They would put the straps in the wrong place, so crisscrossing their straps, and then wearing the device upside down. I was actually a bit shocked that there wasn't a note about folks donning the respirator with it below their nose, because I just feel like I saw that so much in the pandemic, and that's why there's a picture of Don like that. But I do know that that upside down, it happens. When I was doing that fit testing for the hospital, however long ago, which I'm realizing now is 20 years ago too, but I had plenty of people come in and try to don their respirator upside down. And I wish I didn't, but I often saw people do that. This speaks a little bit to the benefit of fit tester accreditation schemes. I mentioned that I wasn't the most competent fit test administrator when I was working for that hospital, because I didn't recognize that you shouldn't, it's unlikely that those masks, particularly just filtering face piece respirators, and I do believe we were using specifically N95s, would fit, 2,497 out of 2,500 people. Like that's not very reasonable. So I should have acknowledged that there's probably some cheating going on. I hate to use that word, but anyway, clearly something was up, and with the fit testing, and I should have noticed that. Whoop, I have no idea what I just did. Okay. So studies have shown that wearers from the public, I didn't even talk about what the other study said. So sorry. So in another study, Dr. Brazeau found that people the majority were able to don that respirator appropriately. So just clearly high variability in groups, but fewer than 25% of them were able to achieve a fit factor of 100, which would be what would be required in an occupational setting. So just high variability with the public using respirators. Studies have shown that wearers from the public have a much greater chance of getting a good fit with a respirator as opposed to just one of the face masks. And then a still better, like so up here is going to be your actual respirators. You've got the highest level of getting a good fit. And then if it's something that's been cleared by the FDA as a surgical mask, then that's kind of next. Then any of the improvised devices, dust masks, loose fitting masks, homemade masks, any of those things we saw. But poor fit and incorrect donning are clearly still quite critical. One of my favorite lines from the Brazeau paper was Brazeau, I'm sure I'm saying that wrong, and I know Lisa, sorry, Lisa. It appears that poor donning practices are not likely to improve with subsequent donnings unless accompanied by assistance training or preliminary fit testing. And first off, it felt very defeatist, but but I agree with Lisa. And so then I wonder, is there an opportunity here to have actual fit testing for the public? I mentioned earlier that fit testing in the occupational setting can help engage a person in their own protection. Maybe we could have clinics that are offer low cost fit testing. This does, introduce some disparity between nations that be able to do so and others that wouldn't. But some of the concerns are medical clearance is what's required now for occupational use. So what does that mean for employer liability? And then also just sort of any abuse. Anytime you're using people, then are you just going to have a bunch of people go out and set up fit test clinics and they don't even know how to fit test respirators and they're just telling people they're good? So stuff you get out. According to a recent literature review, cloth masks were shown to provide only a fit factor of 2 and a median 10% collection efficiency, but they were found inefficient in preventing transmission, which anyway, but albeit better than nothing. Surgical masks were shown to provide a median fit factor of 5, so more than twice that, but with the majority exhibiting collection efficiency between 30 and 50, but with very high variability. So most studies suggest that surgical masks are also insufficient in the prevention of transmission. It's important to notice that both of those are just loose fitting. There is one agency, so ASTM International has attempted to create a standard, and they have. It was released in February of 2021 in response to COVID-19, talking about the devices that cover at least the wearer's nose and mouth and provide a measured degree of particulate filtration. And they're just intended to, if they meet this standard, provide better fit than the other masks and face coverings. But there is no requirement for fit testing. So again, still not going to get that good fit. Some of the other issues with public use, but also with occupational use, I mentioned the firefighters needing to be able to communicate. People came out with clear masks to improve communication. So this was, the top one is Invo mask, and I think the bottom was one from Ford, should be in the reference list when I send it out. I mentioned this earlier, talking about where you can see the pressure points of the FFR. So when you're wearing them continuously, how much discomfort it can create. And so some of the response to that was developing fully contained N95 and higher masks with a wider sealing surface. So these are elastomeric masks, but with pleated filters to lower breathing resistance. The one on the right is the Elastomast Pro. It was designed from requirements in a call out from IOHA, if I recall correctly. And the goal was the respirator to be one solid piece that was able to be disinfected easily with something that was already used by many hospitals. On the left is Respo Lab valveless reusable face piece mask. It's got a HEPA filter, and it has an exceptionally low pressure drop of less than 10 millimeters of water on both inhalation and exhalation. Also talking about use of respiratory protection for the public, there are some things that people are already doing that they need to be using respirators for that they likely aren't. But home renos, some hobby-related activities. I have 2 friends in my neighborhood who are 3D printing in their houses, in their garages. Some of the emerging hazards that we see are, of course, inhalation hazards and related health effects from air pollution. Clearly, the next pandemic was and continues to be an example of this. Viruses transmitted through wastewater, smoke from more frequent wildfires, and then mold and cleanup and remediation of flood damaged materials from the more frequent, natural disasters that we've been seeing. Okay, here's a quick video about the next pandemic, because those, just so we know, there will be another one. And if we don't learn from our mistakes, then we're condemned to repeat them.
The Black Death, the 1918 flu pandemic, COVID-19. We tend to think of these catastrophic, world-changing pandemics as very unlikely events. But between 1980 and 2020, at least 3 diseases emerged that caused global pandemics. COVID-19, yes, but also the 2009 swine flu and HIV/AIDS. Disease outbreaks are surprisingly common. Over the past 4 centuries, the longest stretch of time without a documented outbreak that killed at least 10,000 people was just 4 years. As bad as these smaller outbreaks are, they're far less deadly than a COVID-19 level pandemic. In fact, many people born after the 1918 flu lived their entire lives without experiencing a similar world-changing pandemic. What's the probability that you do, too? There are several ways to answer this question. You could look at history. A team of scientists and engineers who took this approach cataloged all documented epidemics and pandemics between 1600 and 1950. They used that data to do 2 things. First, to graph the likelihood that an outbreak of any size pops up somewhere in the world over a set period of time. And second, to estimate the likelihood that that outbreak would get large enough to kill a certain percentage of the world's population. And this graph shows that while huge pandemics are unlikely, they're not that unlikely. The team used these 2 distributions to estimate that the risk of a COVID-19 level pandemic is about 0.5% per year, and could be as high as 1.4% if new diseases emerge more frequently in the future. And we'll come back to those numbers, but first let's look at another way to estimate the likelihood of a future pandemic, modeling one from the ground up. For most pandemics to happen, a pathogen, which is a microbe that can cause disease, has to spill over from its normal host by making contact with and infecting a human. Then, the pathogen has to spread widely, crossing international boundaries and infecting lots of people. Many variables determine whether a given spillover event becomes a pandemic. For example, the type of pathogen, how often humans come into close contact with its animal reservoir, existing immunity, and so on. viruses are prime candidates to cause the next big pandemic. Scientists estimate that there are about 1.7 million as yet undiscovered viruses that currently infect mammals and birds, and that roughly 40% of these have the potential to spill over and infect humans. A team of scientists built a model using this information, as well as data about the global population, air travel networks, how people move around in communities, country preparedness levels, and how people might respond to pandemics. The model generated hundreds of thousands of virtual pandemics. The scientists then used this catalog to estimate that the probability of another COVID-19 level pandemic is 2.5 to 3.3% per year. To get a sense of how these risks play out over a lifetime, let's pick a value roughly in the middle of all these estimates, 2%. Now let's build what's called a probability tree diagram to model all possible scenarios. The first branch of the tree represents the first year. There's a 2% probability of experiencing a COVID-19 level pandemic, which means there's a 98% probability of not experiencing one. Second branch, same thing. Third branch, same. And so on 72 more times. There is only one path that results in a fully pandemic-free lifetime. 98%, or 0.98, multiplied by itself 75 times, which comes out to roughly 22%. So the likelihood of living through at least one more COVID-19 level pandemic in the next 75 years is 100 minus 22%, or 78%. 78%. If we use the most optimistic yearly estimate, 0.5%, the lifetime probability drops to 31%. If we use the most pessimistic one, it jumps to 92%. Even 31% is too high to ignore. Even if we get lucky, future generations might not. Also, pandemics are usually random, independent events. So even if the yearly probability of a COVID-19 level pandemic is 1%, we could absolutely get another one in 10 years. The good news is, we now have tools that make pandemics less destructive. Scientists estimated that early warning systems, contact tracing, social distancing, and other public health measures saved over 1 million lives in just the first 6 months of the COVID-19 pandemic in the US. Not to mention the millions of lives saved by vaccines. One day, another pandemic will sweep the globe, but we can work to make that day less likely to be tomorrow. We can reduce the risk of spillover events, and we can contain spillovers that do happen so they don't become full-blown pandemics. Imagine how the future might look if we interacted with the animal world more carefully, and if we had well-funded, open-access global disease monitoring programs, AI-powered contact tracing and isolation measures, universal vaccines, next-generation antiviral drugs, and other tech we haven't even thought of. It's in our power to change the threat seriously enough that it becomes a self-defeating prophecy. Which future would you rather live in? What it take about the one?
Surely it'll let me just go to the next slide. So I thought that was really good. Just to kind of show a different perspective, like it's very likely that we will go through another pandemic. And so let's just go ahead and stay prepared almost like, and also when the next pandemic occurs to, in my opinion, sort of ramp up the protection that we provide the public and only tear back as we find out more about the routes of transmission, right? This is a video a person took while evacuating their home in Maui. And so this got sent to me personally. I was shocked. But do you think that they had a respirator handy? How about everyone who's involved in that cleanup? I don't think so. I doubt it. This is clearly a very extreme case. So this is a young man who died after helping clean up after a flood. But as we get more severe weather, this may become more likely. This is just, inhalation hazards aren't everything, but these are some of the hazards that are present in a flooded home that you might not think about. So the emerging issues clearly do not.
Hey, Stephanie,
Yeah.
can we wrap up maybe in a few minutes so that we have enough time? Okay.
Sure. I've got 5 more slides, but I think they're references and questions or something.
Wonderful.
So
wonderful.
the last thing I want to touch on is that you can't just limit it to people in the workplace and say just general public. Children are also going to need to be protected, and respiratory protection for children is going to have all of the same barriers plus some extras. Children are not just smaller adults. This is very similar to the issue of personal protective equipment for women, right? You can't just shrink it and pink it. I've actually experienced difficulty face fitting, so fit testing female faces. And anecdotally, I've heard of many more women in the armed forces here in the United States being hard to fit. That's what we do for respiratory protection with our military. But that's a battle for another day. I know that there's some work going on here. And another issue that's not necessarily child specific, but this just reminded me, is also if you're on the spectrum. So autism spectrum disorder and use of masks. Anecdotal stuff, but we'll just skip past that. Just know that that is something out there. This is almost a shameless plug, but this group is putting together a series of workshops in conjunction with the ISRP. So please do consider looking at this, and if you're interested, reach out to me and help us on our sort of goal to identify some appropriate interventions for the development and implementation from a public health perspective for respiratory protection for children. We can actually kind of skip this. I think we understand that, you know, the modes of transmission is going to be what's most important. What is the material that you're using in your either respiratory protection or your mask? What's the filter efficiency, fit, proper use? I just wanted to kind of point out that the way that we say things can end up sending a different message. So here they say, you know, only used for protection, not prevention. But when we talk, most of the times we're saying that you're doing it as source control and you're not, but it's not actually a contradiction, because they're trying to imply that the bigger thing is to implement higher levels of controls. But you see how someone could take these snippets, like I mentioned earlier, and just they get spread very quickly. So overarching themes: standardize and simplify terminology, globalize guidance for every facet. We want accessible, clear messaging. We want some consensus globally. We want better equipment, so both specialized, you know, for children or for firefighters, and then also general, you know, a nice, comfortable respirator, maybe that's clear for the public. And then let's go ahead and do it now. Let's not wait until the next pandemic happens. Okay. That's all I got. The next slide is just a bunch of references.
You did pretty good job. Okay, this was, I mean, as a part of my day job, I have traveled in 30 countries, maybe 200 workplaces. And the challenges that you are talking about are so, especially APF related. I will make some comments, but let me look at, I can see many people are clapping, and I would join them in clapping, virtual clapping. But let me see what are the questions.
I wish I could see all y'all.
Let me see questions people have been asking. So a comment, there is a correction that in the Netherlands, fit testing is only required for the asbestos workers.
Thank you. Yeah, I'm by no means the foremost expert in European regulation.
Of course, but that's why we would like to make it more interactive. And our IOHA has a member associations in 38 countries. And so therefore all of them bring some knowledge to us. Urbanus, I have a no single organization is always right. We use OEL, different terminologies are used. And there is a paper published by Devau et al. So good, thank you for your feedback. Germany, AGW from TRGS is 900, limits seem to be there. And yeah, so these are the comments. Let me see if anybody has any other question. What would be a preferred choice for the fit testing? CNP or CNC? Now, this is an important question. I will let Stephanie answer. Yes.
It depends on the respirators you're using. If you're using mostly FFRs, then you're going to have to go with CNC, because that's the only technology that's going to be able to fit it. If you're using almost exclusively elastomeric respirators, then I mean, I'm again terribly biased, but I prefer the CNP method, because I can take my machine anywhere. I don't have to do anything with particles, and I don't have to worry about my alcohol and blah blah blah. But that's just me.
No, but it's very important point. Even if you do mask fit testing with CNC, how reliable A is that fit testing, right?
It's all,
and
it's
B,
all fit, yeah.
and I, right, we all know, right, that what happened on the day of fit testing is not going to be there in next day.
No, it's always it's capable of providing that. And that's why I really like to, when I have the opportunity, I do a lot of fit testing with firefighters, and now hospitals because of all the COVID stuff. But in those instances, I have to use the CNC method. But for my firefighters, I just take time and let them run through a few different exercises, adjusting how they have their SCBA on their face so they can see the difference. Because sometimes a subtle adjustment can make a huge difference in fit.
Yep. And yeah, is it possible to get the presentation? If you are an IOHA member association, and I have some concern, there are people attending this session who are not possibly IOHA board members, association member. So please help IOHA in doing right things, okay? We will make sure that
I really love the idea of people breaking into the presentation.
Yeah, yeah. Very interesting. One more question. Can you do CNP test if the half mask only have a filter holder and no other corrections? Where do you
So
connect the tubes?
the way that CNP works is we replace the filter with a fit test adapter. And so it attaches the same way the filter would, and that's where the tubes go.
Very interesting. Yes, I've seen that happening. Very nice. I learned so much even after 30 years in this profession. For example, up until today, I did not know what does NRNP means.
Yeah. And that's
if you're
why I always
handling
have to do, you can't take for granted that people understand these. Like I just learned about FFP 1, 2, and 3 within the past 3
Exactly.
years because
Yeah.
it was just I never needed to. And now that I have to do so much stuff in Europe or internationally, and I didn't understand that it could have such a difference in filtration efficiency. 80% is much less than 95. And so there's a lower level of respirator essentially.
Right. And so if you are an operator working on CNC machine, then you will have to think about oil mist also. And I never knew the classification. Rita, you were saying something?
Yes. Stephanie, would you mind unsharing your screen? And then before people log off, we would like to take a photo. So if everybody can put on their cameras, it would be great.
Yay.
Yay. Oh, I can see Rocio is there from Guatemala.
Yes.
Anna, hi. Guatemala. Who else
Hi.
is there? Hey, good to see you.
Great to see everybody.
Even Bina Patel after a long time. Yeah. Yeah.
Is there some more that wants to put on their camera?
Yeah.
It seems they shy.
Yeah, I'm telling you.
I attend plenty of meetings like still in my pajamas, so
that's right. As long as you can see the face, we are all right. That's an advantage.
Yeah, none of y'all know if I'm wearing pants, so.
Okay, so I'm going to take a photo quickly.
Okay.
Hi. Hi, Shira.
Oh, Shara is also there. Nice.
Shira, yeah. Thanks, everyone. I've got a photo.
Wonderful. So here are things I would like to have a few more comments before we. I can see Alex Wilson also. Oh, BOH's president is here. In case Stephanie, as you can see, and our friend from Japan is there. Right. Yes, and Philip Hibbs is also there. Boy, so happy to see you all. All right, so listen, we have a IOHA 2024 conference coming up in Dublin, Stephanie. Why don't you submit either an abstract on this or a PDC, please?
I will.
And I can provide you the information on how to do this. Okay?
Thank you. I would love to.
Second part is
Ireland.
yeah, and I'll tell you all the good things about Ireland. I spent there two years, almost 2 years. The second thing is, are you open to, and you don't need to answer this question right now, offering the same webinar during evening hours, let's say 7 p.m. New York time, so participants from Australia and New Zealand can also attend. For Philips, it must be what, 2 in the morning, Philip, right now? Or 3 in the morning? Yeah. Anyway, so we will do.
It's just gone midnight, Maharshi.
It's just midnight. Good.
Yeah.
So that was my another request. I have two questions. Methanol and methylene chloride. Air purifying respirators are not recommended because it does not have enough time because vapor pressure is very high. Has any research been done?
You mentioned that to me, and that was the first that I had heard. So I didn't want to touch on it because I didn't know. But yeah, I tried to reach out to a couple people who I think would know, but I haven't heard anything yet.
So 3M mentions this, that you cannot use the air purifying respirator for methanol. Now, in pharmaceutical industry, methanol is very widely used for disinfectant and other use. So I thought if you have heard something new, we can learn from you.
If I get it between now and the next time I present this, I'll add it in, and I'll try to trim my commentary.
No worries. And the APF controversy is also huge. Again, in pharma industries, when you are using a PAPR with a hood, right? OSHA talks about 25 APF or 50 APF. Versus some agency gives 1,000 APF for the same PAPR.
Samantha and I are actually working on a paper sort of figuring out where those were derived and how and why for the synergist. And I think that's supposed to be published later this year. So we're actively working on it. We're meeting in Portugal next week to sort of iron out why do we have, why do those differences exist, right? Because that's one thing I know they exist. And I know some of the justification from some of the different agencies, but I don't know all of them. So we're trying to figure out all the different reasons why people have different assigned protection factors.
So we keep looking at the opportunities. The IOHA publishes a quarterly magazine called Global Exposure Manager. And Samantha and I have already talked about, maybe you and Samantha can come together. Next one is in October. It may be too early for you because publication will go out sometime end of this month. But the following issue, why don't you, Stephanie, and Samantha come together and actually have an article, Emerging Issues in Respiratory Protection?
Okay, that sounds good.
All right. And our new IOHA board members from Nigeria, Matthew, is saying thank you. They just joined IOHA 2 weeks ago.
Yeah, I'm gonna have to, I wonder if I can just download this chat so I can see, because I didn't get to see it while I was presenting.
Yeah, maybe I will request Rita to do this. So, hey, everyone, thank you so much. Thank you again, Stephanie, for a really learning session. And this is such an important topic because we are relying so much on respiratory protection, whether it's a silica exposure, silica, or a pharmaceutical, potent pharmaceutical compound. And if that is not providing the protection, then the health of the people is at stake.
Absolutely.
Right. So I'm so happy for this. Thank you so much. And you have exceeded all the expectations. All right. So everybody else.
I told you to keep them low. So good.
No, so that's the reason I wanted to end by letting you know. Hey, everyone. Thank you so much for participating. Look for the webinar. Next one, there is a possibility on local exhaust ventilation sometime in November. And then soft skill in occupational hygiene. Lena and I, and maybe someone else from US, we are working. If you would like to participate, I can see Alex, Philip, anybody else as a speaker, please let us know. All right, with that, I think we are pretty much on time. It's 3 minutes after 10. Any other comments, question, maybe one or two more if you have. Otherwise, we can end. Fantastic presentation.
Thank you so much, everyone. Thanks for attending.
Thank you.
Bye-bye, everyone.
Good day.